Heart failure is a very common condition that is actually quite often misunderstood by medical students because I don't think the definition is actually explained particularly clearly. So the best definition of heart failure that I could find is that it's a condition where the pumping of the blood by the heart is insufficient to meet the demands of the body. So it is quite literally just a supply and demand issue, but the ways that it manifests are a little bit varied. So to break it down to absolute basics, we have blood going into the heart and we have blood coming out of the heart. So if blood isn't coming into the heart quite as well, it leads to congestion in the right side of the heart that causes peripheral edema, and on the left side it causes pulmonary edema. And if the heart is unable to pump out blood effectively, it leads to a drop in cardiac output, which in turn leads to various other problems such as shock, tachycardia, and AKI. So often heart failure may be categorized as either preserved or reduced ejection fraction, and I'll explain exactly what that means, but first of all we'll break it down to the basics of how a ventricle functions. So the main measure of ventricular function will be the cardiac output, and that's defined as the stroke volume multiplied by the heart rate. So in other words, how much blood is being pumped out by the ventricles every minute. Then the ejection fraction is another important measure to be aware of, and that is defined as the stroke volume divided by the end diastolic volume. So in other words, how much of the blood that is in the ventricles at the end of diastole is pumped out into the systemic circulation. So in order for the heart to achieve an adequate cardiac output, it needs to fill adequately during diastole, and then it needs to empty adequately during systole. Simple enough. So heart failure with preserved ejection fraction is caused by inadequate filling of the ventricles during diastole. So just to define it a bit more specifically, preserved ejection fraction refers to a left ventricular ejection fraction that's more than 50%. So the main reason this happens is because of stiffness of the ventricles, and that may be due to a number of reasons, such as volume overload in valve regurgitation, pressure overload, or decreased distensibility. But the underlying principle is that during diastole, the ventricles are not able to fill sufficiently with blood, and hence it means that there's not enough blood to pump out during systole. So the proportion of the blood that's pumped out during systole may be perfectly fine, above 50%. However, the actual amount of blood that's coming out is quite low, because the heart isn't filling quite as well as it should be. Heart failure with reduced ejection fraction, on the other hand, is defined as an ejection fraction of less than 40%. And that's due to inadequate emptying. That may be due to an outflow obstruction, such as aortic stenosis, or it may be due to impaired contractility. So quite often, patients who've had a myocardial infarction will have part of the heart muscle which is not contracting quite as well as it should be, and hence it's unable to expel blood from the ventricles quite as well as it would otherwise. So in this case, the ventricles are able to fill adequately during diastole. However, the contractile mechanism is impaired or the outflow is obstructed, meaning that you can't actually pump out as much of the blood from the ventricles as you would like to. So you may note that reduced ejection fraction is defined as less than 40%, and preserved ejection fraction is defined as more than 50%. So there is this middle ground called intermediate ejection fraction, where it sort of has features of both types. So now let's have a look at investigations for heart failure. So at the bedside, an ECG is very important, especially if a patient is presenting with acute heart failure. It could be due to some sort of ischemic event. Bloods-wise, an ABG is important if there is some level of left heart failure resulting in pulmonary edema. Troponins and BNP should also be requested. And imaging-wise, a chest X-ray is important if there's any respiratory compromise, and an echo can help actually establish some of these parameters, such as the ejection fraction. In terms of the management, in acute heart failure, you need to sit the patient up straight away and give them high-flow oxygen via a non-rebreathe mask. The medical treatment mainly involves giving furosemide to try and remove some of the excess fluid from the body and lessen the strain on the heart. GTN and morphine can also help reduce the preload on the heart. Long term, there's a bunch of medications that are used in the management of heart failure. So diuretics are important in managing the symptoms of heart failure and making sure that the patient doesn't become fluid overloaded. However, they don't have a prognostic benefit. Beta blockers, ACE inhibitors, and SGLT2 inhibitors have been shown to have a prognostic benefit in patients with heart failure with reduced ejection fraction. At the moment, there aren't any classes of medication that are shown to improve outcomes in patients with heart failure with preserved ejection fraction. Other risk factors should also be modified. So for example, if the patient has diabetes, it would be worth reviewing that to make sure that they are maintaining good glycemic control. So let's just have a quick look at the imaging. So here we can see there's a lot of fluffy alveolar shadowing, and that's typical of pulmonary edema. And I often find it's useful to have a look at a normal chest x-ray to be able to compare what the abnormality actually is. So the fluffy airspace and shadowing is suggestive of pulmonary edema.